Well, good afternoon and good morning, everyone, and good evening, I should say, to those of you in the UK and Europe. My name is Paul Weber, and it is my honor today to introduce Dr. John Boyce and his teleclass lecture, Update on Methods for Cleaning and Disinfection of Environmental Surfaces. Actually, in point of fact, this is the 7th time that we have had the privilege of introducing a John Boyce teleclass, starting almost exactly 13 years ago. And all of those past lectures actually remain available in our free access recordings library. Last year, Dr. Boyce retired from his positions as the Director of Epidemiology and Infection Control at Yale New Haven Hospital, and also the position as Clinical Professor of Medicine at Yale University School, that is, say, the School of Medicine, but he remains very active in infection control and epidemiology through his consulting practice. And the website for that consulting practice, the URL for that, is on the title slide. I would encourage you to go and look at the website and all of the things that Dr. Boyce does. His list of accomplishments and interests over a 40-year career in infectious diseases and healthcare epidemiology is really just too long to cover in this introduction. And anyway, I dare say that we are all very familiar with his work. Let me just point out that he has published something like 150 papers in peer-reviewed publications, and he has authored or co-authored 28 or I think 29 book chapters. During his years as infectious disease attending physician, he received several awards as Best Teacher and as Research Attending Physician of the Year. Before Dr. Boyce begins, I would also like to acknowledge Sealed Air Diversity Care for their sponsorship of this teleclass lecture in particular, and for their generous support of the teleclass education program as a whole. Now, John, I am really pleased to be able to welcome you back again, and the floor is yours.
Thank you, Paul, for giving me this opportunity to speak again today. So if we move to slide 2, I've listed the topics that I'm going to discuss, which include the general principles for use of surface disinfectants, some of the current options we have for products, the methods used for application, and some automated no-touch methods for surface disinfection. Next slide. David Weber and William Rittal have published these general principles for using surface disinfectants a number of years ago, and the only reason I show them is that they are still very pertinent, and I know that sometimes our colleagues don't always follow these, so they're worth mentioning. They recommend using disinfectants approved by whatever your federal agencies are. In the U.S., that would be the EPA, to use disinfectants at their recommended concentration or dilution and make sure we don't over-dilute them. To use disinfectants for the recommended contact times, and to not use antiseptic solutions for surface disinfection. We need to follow recommended procedures for preparation of products, and small volume dispensers that are refilled from large volume stock containers should be used until entirely empty, then rinsed with tap water and air dried until they are refilled. That's kind of a minimum process. And then we should store stock solutions as recommended by the manufacturer. Next slide. Our choices of surface disinfectants include quaternary ammonium compounds that may or may not have alcohol in them, sodium hypochlorite or bleach, and other chlorine-releasing products, improved hydrogen peroxide products, combinations that include peracetic acid and hydrogen peroxide, alcohols, phenolics, and aldehydes. Iodophores are not generally recommended for cleaning large surfaces. Dr. Ratala pointed out that the ideal disinfectant for all purposes and against all pathogens doesn't really currently exist. Now, quaternary ammonium compounds, which I'll call quats, are widely used for low-level disinfection of surfaces in healthcare. They are inexpensive, particularly in a dilutable form. They're relatively good cleaning agents. They're compatible with many surfaces, and they do have persistent antimicrobial activity. However, they're not sporicidal. They're not very good for non-envelope viruses like norovirus. Some products require the use of personal protective equipment. Their activity can be affected by organic material. Some products have long contact times, like 10 minutes on their label. They can bind to cotton and cellulose wipes, and there have been a number of outbreaks due to contaminated quat solutions. Now, a fairly popular approach to surface disinfection, at least in several countries, is to take a concentrated quat solution and then dilute it with water, sometimes using an automated dispensing system like the picture on your left, and then placing the diluted disinfectant in a reusable bucket with a roll of dispensable wipes. Let's go on to the next slide, number 7. Well, recently we tested disinfectant solutions obtained from 33 automated dispensing stations in the hospital, and the quat concentration that was delivered by these stations was tested using a simple strip test. And much to our surprise, we found that 2 stations delivered solutions with no detectable quat. 7 stations yielded solutions with less than 200 parts per million. Other stations delivered solutions that either were between 200 to 400 ppm or maybe 400 to 600 ppm. But in fact, the manufacturer recommends that we use this product at a concentration of 800 ppm. Turns out that differences in water pressure in parts of the hospital and the design of the concentrated jugs of disinfectant were responsible for delivery of inappropriate in-use concentrations. So my recommendation based on this would be you may want to consider periodic testing of diluted solutions to make sure that the in-use concentration is correct. Next slide. Contamination of reusable buckets of quats has been another issue. 2 studies in Germany assessed the frequency of contamination of reusable buckets used to dispense disinfectant wipes. In one study, 42% of buckets that contained a surface active disinfectant like a quat were heavily contaminated with bacteria, frequently Achromobacter species. In a second study, 47% of reusable buckets were contaminated. And it turned out that failure to process these reusable buckets, according to manufacturer recommendations, is what contributed to the frequent contamination of the disinfectant solutions. Next slide. Of course, this problem isn't confined to Germany by any means. A few years ago, we were doing a study where we were culturing surfaces just before and just after they'd been cleaned. This culture plate on your left shows that cultures of an overbed table done just before cleaning only showed a few colonies, but just after cleaning, the culture showed hundreds of colonies of gram-negative rods. Most of them were Serratia with some Achromobacter. Investigation revealed that the reusable bucket of quat contained high concentrations of Serratia marcescens, and yet testing of the disinfectant in the bucket showed that the solution still inhibited the growth of a sensitive strain of Serratia, and whole genome sequencing of the contaminating strain by collaborators revealed the presence of 4 CAC resistance genes that allowed this Serratia strain to survive and actually grow right in the bucket of disinfectant. So again, the recommendation would be to follow your manufacturer's recommendations to how to clean and disinfect buckets before refilling them. Now, sodium hypochlorite or other chlorine-releasing disinfectants are frequently used when Clostridium difficile or Ebola virus or norovirus or some of the other non-envelope viruses are of concern. These kind of compounds have broad-spectrum germicidal activity. They're fast-acting. They're inexpensive in the dilutable forms. They're not flammable. Sometimes they can actually reduce biofilm on surfaces, and they're relatively stable. But there is a risk of reaction of these products with acids and ammonias. They may be corrosive to some types of metals. Their activity can be affected by organic material. Sometimes they may discolor or stain fabrics. And some products may have an unpleasant odor. And when used in high concentrations, they can be irritating. Multiple studies shown on slide 12 have confirmed the effectiveness of sodium hypochlorite or other chlorine-releasing agents or wipes to reduce environmental surface contamination and sometimes to reduce Clostridium difficile infection. These products, I think, are most effective if they're used both for daily as well as terminal disinfection of rooms occupied by patients with Clostridium difficile infection. Next slide. Sodium hypochlorite and other chlorine-releasing products have also been widely used to control outbreaks of norovirus and to prevent transmission of Ebola virus. In fact, for Ebola virus, the CDC recommends using a disinfectant like one of these against non-envelope viruses as a special precaution, and the World Health Organization suggests use of a 0.5% chlorine solution to prevent transmission of Ebola virus. Next slide. Now in Canada, and maybe to a lesser degree in other countries, improved hydrogen peroxide, or IHP, disinfectants are being used instead of cloth disinfectants for surface disinfection. These products are also effective against many pathogens. They are fast-acting. They're safe for workers. They're benign for the environment. They have good compatibility with surfaces, and they're non-staining. There's relatively few disadvantages here, as they tend to be more expensive than some of the other disinfectants, and they're not sporicidal when used in low concentrations. One prospective study of a 0.5% IHP product significantly reduced C. difficile spores on toilet seats of CDI patients, even though it's not rated as a sporicidal product. In a laboratory study, IHP liquid disinfectants containing either 0.5% or 1.4% hydrogen peroxide were found to be superior or equal to the cloth that was tested. And then a recent study by Dr. Sitar and others that used an ASTM standard for evaluating disinfectant wipes found that all the wipes that were tested achieved greater than a 4-log reduction of Staph aureus and Acinetobacter baumannii, but only the IHP wipe containing 0.5% hydrogen peroxide prevented the transfer of bacteria from one surface to another. In other studies, An IHP wipe that looked at a 1.4% hydrogen peroxide product was used to disinfect 10 high-touch surfaces in 72 patient rooms, and it resulted in 99% of surfaces having less than 2.5 colony-forming units per centimeter on the surface after cleaning, which some people use as a criteria for a clean surface, and 75% of surfaces yielded no growth. In another study, an IHP spray product containing 1.4% IHP reduced microbial load on patient privacy curtains by 96.8%. And another study showed that IHP wipes effectively disinfected surfaces in an operating room. And then finally, a study of soft surfaces sprayed with an IHP product or with a 1 to 10 dilution of household bleach found that both reduced MRSA and VRE by more than 6 logs with a 1-minute contact time. Next slide. A hospital-based interrupted time series study done in Canada compared a hydrogen peroxide cleaning agent to a 0.5% IHP disinfectant disposable wipe. And what they found was that when 80% of surfaces were wiped by housekeepers, use of the IHP wipes was associated with a significant reduction in healthcare-associated infections caused by MRSA, VRE, and C. difficile. The study did have a few limitations, which were acknowledged by the investigators. A more recent 12-month prospective crossover control study involving 4 units in a hospital compared a quat and a 0.5% IHP wipes for daily and terminal room disinfection. What we found was that the IHP wipes yielded significantly lower colony counts after cleaning and a significantly greater proportion of surfaces that had no growth after cleaning. There was a 23% reduction in a composite healthcare outcome that included multi-drug-resistant organism acquisition and infection, although this 23% reduction didn't quite meet statistical significance. Slide 18 shows that due to continuing difficulties in preventing C. difficile infections, some new sporicidal disinfectants, including peracetic acid and hydrogen peroxide disinfectants, have been introduced. These compounds also have broad-spectrum germicidal activity. They're active in the presence of organic matter. They have environmentally friendly byproducts and are surface compatible. They do have some problems with stability and have the potential to be incompatible with brass and copper. They tend to be more expensive than most other disinfectants. And some products may have an irritating odor. One prospective randomized trial in a long-term care facility used this product to clean high-touch surfaces daily, and they compared this with only cleaning high-touch surfaces when they were visibly soiled. And what they found was daily cleaning with this peracetic acid-based product reduced the frequency and the colony counts of C. difficile and MRSA on surfaces, and importantly, it reduced the contamination of hands of healthcare personnel. These two graphs here on the y-axis both show the percent of hand cultures that were positive. The top graph shows the results for C. difficile, the bottom for MRSA. And on both graphs, you can see that the white columns show that when they disinfected these high-touch surfaces daily with the peracetic acid, that a much lower proportion of the healthcare workers had positive hand cultures. Next slide. In other studies, a peracetic acid hydrogen peroxide disinfectant was shown to be effective as bleach in killing MRSA, VRE, and C. diff spores in vitro, and was also highly effective at removing the 3 pathogens from high-touch surfaces. In another study, where they compared a quat and a peracetic acid hydrogen peroxide disinfectant, they found no growth of bacteria after cleaning on only 40% of surfaces cleaned with a quat disinfectant, but 77% of surfaces cleaned with the peracetic acid hydrogen peroxide disinfectant, a clearly better result. There are some problems with these compounds, including the odor of some products may be irritating to housekeepers. A few hospitals in the U.S. have actually discontinued the use of this kind of product due to complaints about odor, while many other hospitals continue to use these products successfully. At least some of these combination products require an activation step by mixing 2 components on site due to stability problems. And one product was actually removed from the market in the United States in 2015 due to insufficient activity against C. diff spores. Again, a problem of its stability. Next slide. Now, what about alcohols? Because isopropanol and ethanol evaporate rapidly, they've not really been recommended for disinfecting large surfaces, at least in U.S. guidelines. They do have broad-spectrum germicidal activity. They're fast-acting, non-corrosive, non-staining, and they don't leave any toxic residual. And they have been used for years to disinfect small surfaces like the top of a medication vial. However, they're not sporicidal. Their activity can be affected by organic matter. By themselves, they have relatively poor cleaning properties. And in the United States, they haven't been EPA registered for use on large environmental surfaces. They can damage some types of instruments that have hard rubber or glue as part of the instrument. And again, because they evaporate rapidly, there's been a concern that they may not be on the surface long enough. They can be flammable, and there's one pseudo outbreak reported where alcohol was used as a disinfectant. Next slide. Alcohol concentrations ranging from 60 to 90% have been used for years to disinfect small objects. And then there's a new alcohol-based formulation that was recently marketed. This has a lower concentration of alcohol plus some other ingredients that affect its performance. It also has broad-spectrum germicidal activity and is effective against norovirus as well as envelope viruses. It has a short contact time of only 30 seconds for 22 different organisms. It's EPA registered for use on large healthcare environmental surfaces, and it carries an EPA Category 4 rating, which means that no personal protective equipment is needed. It can also be used on food contact surfaces, but it is not sporicidal. Phenolics have broad-spectrum germicidal activity, are inexpensive in dilutable form, non-staining, they have no toxic residua, and are non-flammable. They tend not to be sporicidal, and they can be absorbed by porous materials, which can be irritating if they come in contact with the skin. And some products may cause skin depigmentation, and they can cause hyperbilirubinemia in infants if they're not used correctly. Aldehyde-based products are used for surface disinfection in some countries, especially in Europe, but they're not really used for this purpose in the United States. They do have broad-spectrum germicidal activity with short contact times, good cleaning ability, and good material compatibility. Not all formulations are sporicidal, and they can cause some skin and respiratory irritation in some users, and there's been some concern about their environmental impact. Next slide. Now I'm going to move on to methods used to apply disinfectants to surfaces, and they include cotton towels or rags, reusable microfiber cloth, and a variety of different disposable wipes. One thing that I think is not well known among housekeepers and infection control people is that cotton and cellulose-based wipes, and to a lesser degree microfiber, can bind these clot disinfectants. And this binding reduces the concentration of clot that's delivered to surfaces by your cloth or your wipe. The impact of this binding phenomenon on reducing pathogens on surfaces, I think, is not well studied yet, but I think it really warrants further investigation. Next slide. We looked at clot binding of different types of wipes. On this slide, the y-axis shows the concentration of the clot disinfectant in parts per million, and the x-axis shows the amount of time that cloths or wipes were allowed to soak in a bucket of clot disinfectant. So the top solid line shows what happens when a disposable wipe that was specifically designed for disinfectants was allowed to sit in the clot for 240 minutes. And it shows that the amount of clot released by the disinfectant decreased from 800 down to 600 parts per million. The dashed line below it shows the results for microfiber cloth, which, when allowed to soak in the clot for 4 hours, only released 400 parts per million from the cloth when it was squeezed onto a surface. The dotted line shows the results for cotton towel, which only released 100 to 200 ppm after being in the clot for periods of time. And the bottom line was for a wipe that was actually designed for use with solvents rather than disinfectants. Next slide. So the nice thing about cotton towels and cloths are they're inexpensively and they're readily available. However, at least one study showed that they may still be contaminated with bacteria even after they've been laundered, and that they could spread C. difficile spores to other surfaces if not used correctly. Now, new microfiber cloth can remove bacteria from surfaces better than cotton cloth. That's been shown by a number of people. You should know that commercially available microfiber cloths can vary considerably in how well they remove bacteria from surfaces, and that their ability to clean surfaces is adversely affected after laundering or drying multiple times at high temperatures or exposure to sodium hypochlorite. And depending on how they're used, they may have the capability of spreading bacteria to surfaces. Slide 29 shows some of the advantages of disposable wipes, which seem to be becoming more popular in the U.S. and possibly other areas. These eliminate the need for laundering of cotton and microfiber cloths. They're easy to use, ready-to-use pre-packaged wipes eliminate the need for either dilution or preparation of the disinfectant by housekeeper, something I've shown you can be a problem sometimes. One study showed that personnel actually preferred the wipes to the bucket method and that it required less time to use wipe it than the bucket method. There are disadvantages, and they include the fact that these ready-to-use wipes are more expensive than using dilutable disinfectants with reusable cloth. And I'm guessing that may relate in more waste disposal. And the ability to remove bacteria from surfaces, again, may vary among these ready-to-use wipes. Slide 30 makes the point that we should make sure to recommend that we use the correct number of wipes per room. Using too few wipes per room can actually spread bacteria from one surface to another. This picture shows 3 rows of culture plates. The top row shows that when a bench top was contaminated with C. difficile spores, and then a fresh bleach wipe was used to wipe that contaminated surface, and then it was used to wipe 4 uninoculated clean surfaces with the same wipe. What the top row of, and those surfaces were then cultured. These culture plates on the top show that this fresh hypochlorite or bleach wipe didn't transfer any spores from that bench top to those other 4 clean surfaces. However, if they used a used hypochlorite wipe, there was some transfer from that bench top to these other 4 clean surfaces. You can see there's some growth on those culture plates. And then when they used the quaternary ammonium wipe, which of course is non-sporicidal, there was incredible transfer of spores from that bench top to those other 4 surfaces that had previously been clean. So the 2 points in this slide are make sure that you use your wipes correctly, and it's recommended that you use a sporicidal wipe when you're cleaning surfaces that you think are contaminated with Clostridium difficile. Next slide. I found few publications that have talked much about the cost of disinfectants. It's pretty clear that dilutable cloths and bleach solutions are relatively inexpensive. The acquisition cost of disposable wipes is clearly higher, but you do avoid the cost of replacing microfiber cloth and for laundering of cotton and microfiber cloth. One study shown at the bottom of the slide here, they looked at the cost per wipe and found that a quat wipe only costs 3 cents, an alcohol wipe costs less than 2 cents, but one of the acetic acid wipes costs like 47 cents. So there's clearly a difference in cost between some of these wipes. Next slide. Now I'm going to move on to no-touch decontamination methods. In many facilities, as you know, less than 50% of high-touch surfaces are actually wiped by housekeepers at the time of terminal room cleaning. And in response to this problem, no-touch automated systems have been developed to decontaminate patient rooms after discharge. I've listed on this slide a number of examples. I won't be able to touch on all of these, but I will mention a number of them. Next slide. Aerosolized hydrogen peroxide dry mist systems utilize portable units, and they aerosolize usually a 5 or 6% hydrogen peroxide plus or minus some silver ions, plus some stabilizers. These aerosols, unlike vapor-based systems, have a particle size ranging from about 0.5 to 12 microns. And these systems use passive aeration so that the hydrogen peroxide is left to degrade naturally in the room. And this results in a cycle time of more than 2 hours for a single room for a number of these different systems. Next slide. These aerosolized hydrogen peroxide systems generally have reduced indicator spores by about 4 logs or less. Cultures obtained before and after cycles have demonstrated significant reductions in bacterial, including spore counts, both in laboratory settings and in patient care areas. Although in a couple studies, they did not completely eradicate the C. difficile spores. One system has gotten a sporicidal claim from the EPA in the United States. More recently, an aerosolized hydrogen peroxide system that emits 7.5% hydrogen peroxide was tested for activity against several types of spores on carriers that were located 80 centimeters from the device. After only a 1-hour exposure in a half-open drawer, few C. diff spores were killed, although there was a 10 to 5 log reduction of sterile thermophilus spores. But after a 3-hour exposure, there were no viable C. diff spores recovered, and there was still a 5 log reduction of both C. diff strains that were tested. Next slide. In one before-after study that compared aerosolized hydrogen peroxide system to the use of a detergent for room cleaning, found that the aerosolized hydrogen peroxide was associated with significant reduction of MRSA acquisition and some reduction of MRSA infection. Maybe it's not too surprising since they just compared it to a detergent. And for these types of systems, so far there's no randomized controlled trial of their impact on healthcare-associated infections. Next slide. There's a dry gas vaporized hydrogen peroxide system that utilizes about 30% hydrogen peroxide. It's been shown to be effective against a whole variety of pathogens of concern. In some before-after studies, this dry gas vaporized hydrogen peroxide system, when it was combined with other infection control measures, did appear to contribute to the control of outbreaks of Acinetobacter in a long-term care facility and in 2 intensive care units in a hospital. Again, there's no randomized controlled trials of the impact of this particular system on healthcare-associated infections. Next slide. There's a microcondensation hydrogen peroxide system which uses closer to a 35% hydrogen peroxide, and this is also shown to be effective at eradicating a number of important pathogens shown on the slide here. Both laboratory and in-hospital studies document significant reductions of a number of these pathogens, with a 92% to 100% reduction of pathogens on surfaces in most of the studies. Next slide. This microcondensation hydrogen peroxide vapor system has been looked at in probably one of the best studies of the type. It was a 30-month prospective cohort study on 3 intervention wards and 3 control units in a tertiary hospital at Johns Hopkins. environmental contamination by and patient acquisition of VRE, MRSA, C. difficile, and resistant gram-negative rods were studied in rooms decontaminated with hydrogen peroxide vapor versus standard cleaning. And what they found was that patients that were admitted to rooms that were decontaminated with the hydrogen peroxide vapor were 64% less likely to acquire a multi-drug resistant organism in general, overall, and about 80% less likely to acquire VRE. Fewer patients acquired MRSA, C. diff, and resistant gram-negative rods, but the reductions did not reach statistically significant levels, I guess in part because the most dramatic effect was with VRE. The percent of rooms contaminated with MDROs was significantly reduced on the HPV units, but not on control units. Next slide. In before-after trials of this system, when it was used in conjunction with other measures, appears to have controlled outbreaks caused by MRSA, resistant gram-negative bacteria, and Clostridium difficile. It's also been used to decontaminate rooms previously occupied by patients with loss of fever or Ebola virus infection. Again, to date, there's no randomized controlled trial of the impact of this system on HAIs. Next slide. Hydrogen peroxide vapor and the aerosolized hydrogen peroxide are clearly different processes with different effectiveness in eliminating pathogens, and that's something you need to keep in mind. Two head-to-head comparisons of one aerosolized hydrogen peroxide system versus the microcondensation HPV system revealed that the HPV was significantly more effective than the aerosolized system against spores, and that the cycle times were pretty similar for the two processes. So the HPV was significantly more effective in eradicating spores than the aerosol peroxide system that was tested in these studies. Next slide. One of the concerns that needs to be taken into account if you're using a vapor-based system is that you need to seal up the air vents and the doors in the room before you turn on the machine. The total cycle times for the microcondensation process has generally been about 2 to 2.3 hours, although this may be lower with some of the newer equipment that's coming out. For the dry gas process, it was more like 8 hours. The microcondensation HPV process has been shown to actually be feasible to use in hospitals with high census levels. But you need to keep in mind that the level of training and expertise of the operators is clearly greater with the HPV systems than with something like a mobile UVC light unit. There's no randomized controlled trials of the impact of this kind of system. Next slide. The automated mobile UV light units that emit UVC in the range of 254 nanometers can be placed in patient rooms after patient discharge and terminal cleaning has been done. These units sometimes can be set so that they can kill either vegetative bacteria or to kill spores. This slide shows only a few of the different systems that are on the market currently. Cultures obtained from surfaces that were inoculated with C. difficile, MRSA, or VRE, and obtained before and after UVC light decontamination show that in general, you get about a 3 to 5 log reduction of MRSA and VRE, and more like a 1 to 3 log reduction of C. difficile under experimental conditions. So you get significant reduction, but sometimes without complete eradication of the pathogens. Some studies have shown that surfaces that are in shadowed areas that are not in direct line of sight of the UV device may not be disinfected as well, although several other studies, it seemed like shadowed areas did okay in terms of reduction of bacteria. Efficacy of these systems is clearly affected by the cycle time, how long it is, the distance of objects from the device, and the presence of organic material. Next slide. The parameters that are used when testing these kind of systems can also affect the results in terms of the UVC irradiance, that's the intensity of light, and the antimicrobial activity. And these parameters that can affect the results include the area over which the bacterial inoculum is spread onto the test surfaces, the distance and orientation of test surfaces relative to the UV device, and the types of organic load that are used. On this slide, it shows the mean UVC irradiance or intensity on the y-axis, and on the x-axis, it shows that if you take a UVC sensor and you point it directly at the UV device at a distance of 4 feet, you get a high intensity of UV light. But in other distances from the UV device, or when objects are oriented differently and aren't looking directly at the device, you clearly get lower degrees of intensity, which is something that may affect the results you get. Next slide. Currently, there's pretty limited published data on the impact of UVC light systems on the incidence of healthcare-associated infections. However, you should know that there is one multi-center prospective cluster randomized crossover trial of UV light for terminal disinfection in hospitals, in nine hospitals. And what they did is they compared a standard quat disinfectant alone, the standard quat disinfectant plus UVC light, sodium hypochlorite alone, or sodium hypochlorite plus UVC. And the outcome measures were either colonization or infection among patients who were exposed to rooms that had previously been occupied by a patient with MRSA, VRE, or C. difficile. Next slide. The preliminary results, which have been presented at a meeting, showed that bleach and or UVC enhanced room decontamination decreased the clinical incidence of MRSA, VRE, and C. difficile by about 10 to 30%. And the amount of reduction clearly differed between the 3 different types of organisms. I'm thinking that this important study will probably be published in the near future, so you want to be on the lookout for it. Next slide. Some issues you need to think about if you're thinking about a mobile UV light system is ease of use, duration of cycle times, the evidence of its microbiological efficacy, preferably published by independent investigators, the cost of the devices, which can vary considerably, the cost of replacement bulbs and service contracts, and whether or not the system has kind of a digital recording system that can store and from which you can retrieve data about which rooms were decontaminated. Next slide. One study compared HPV to a mobile light system. This was done in 15 rooms. Each room was decontaminated once with HPV and then with a UVC light device. Of the sites that had a positive aerobie colony counts before decontamination, 93% yielded no growth after HPV, whereas 52% yielded no growth after the UVC light treatment. Mean log reductions were greater with HPV than with UVC. Mean cycle times were clearly longer with HPV than with UVC. HPV was significantly more effective in rendering surfaces culture negative and more effective against spores, but the UVC device was clearly faster to use and easier to use. Next slide. So some of the things you need to think about when you're thinking about peroxide vapor versus UVC are shown on this slide, and it kind of depends a little bit on how you intend to use it. On this slide, on the left column, shows that if the intended use, if you want to decontaminate a relatively large proportion of rooms, then the UVC probably has an advantage. The hydrogen peroxide vapor has the advantage if you want to decontaminate primarily rooms with really difficult to kill pathogens or highly virulent pathogens, like Ebola or bugs that are really tough to get rid of. It also, you need to think about the level of efficacy that you're looking for. For continuous UVC or pulse xenon, you do get significant reduction of pathogens, whereas with hydrogen peroxide vapor, you get near total or total eradication of the pathogen. And you need to think about cycle times, which are anywhere from about 15 to 45 minutes with the UV light systems, compared to about 2 hours or more with the hydrogen peroxide vapor. Next slide. There is a pulse xenon system which uses pulse xenon instead of mercury bulbs to create UV light. The system emits flashes of UV light in the range of 200 to 280 or maybe up to 320 nanometers. The manufacturer recommends placing the device in 3 locations in a patient room with 5 to 7 minute cycles. Several studies have shown significant reduction of pathogens in patient rooms utilizing this system. Next slide. One study compared one of the continuous UVC systems to this pulse xenon system, and they looked at B. difficile, MRSA, and VRE pathogens. And on the on the right-hand column, you can see the log reductions achieved for each of those pathogens by the pulse xenon system on the top 3 rows and the UVC system on the bottom 3 rows. Both systems reduce pathogens on surfaces, and the UVC system showed greater log reduction than the pulse xenon system. Next slide. Some of the concerns regarding the mobile UVC and pulse xenon systems are that currently there's no randomized controlled trials of the impact of these systems, particularly of the pulse xenon system. A number of systems have been marketed, often with limited documentation about their effectiveness, and this makes the choice of device kind of difficult for a lot of hospitals. There are substantial differences between the systems regarding the recommended cycle times and the upfront and maintenance costs. Certainly with the UVC systems, sometimes there's kind of a funny odor that you detect when you walk into the room as soon as the cycle is finished. This sometimes has kind of bothered healthcare workers a little bit, but to date there's no evidence that the odor is harmful. High-intensity narrow-spectrum light, which is more in the range of 405 nanometers, there's this one system out there that can be set so that the light either appears blue-colored or more white-colored. This system, unlike the UVC and pulse xenon systems, you can leave the system turned on when patients or personnel are in the room, and it's been shown to reduce staphylococci on surfaces. We clearly need further data to determine the role that this kind of system is going to play in air on surface disinfection, but it's pretty interesting. We'll definitely need to see what further studies come out. Very few data are available regarding the cost effectiveness of the new no-touch room disinfection technologies. In one hospital, C. difficile disease incidence density decreased from 11.8 cases per 10,000 patient days during 10 months before use of HPV and 8.7 cases per 10,000 patient days during the 10 months after HPV, about a 37% reduction. The estimated number of C. difficile cases prevented in the 10 months was 33, and kind of a crude cost estimate based on published data suggestion that there was a clear cost savings to the hospital. A study of using HPV to decontaminate disposable medical supplies that are usually discarded after patient discharge revealed that a potential annual cost savings to one hospital of more than $350,000. Next slide. HPV technology costs vary depending on whether devices are purchased by the hospital versus paying for the services of an implant team from the manufacturer. Mobile UVC light and pulse xenon devices vary in price significantly, and service contracts and bulb replacement costs have to be taken into consideration when you're looking at these systems. We clearly need more studies of the cost effectiveness of both HPV and UVC and pulse xenon systems. Next slide. Some other gaseous or fogging technologies that I can't really go into in detail include gaseous ozone, which has been proposed for a method of room decontamination, alcohol-based fogging system, which was shown in one study to be less effective than bleach. Chlorine dioxide fogging is promoted for room decontamination, but few studies have been done in hospital settings. And then a hydrogen peroxide parasitic fogging showed significant log reductions of spores in one laboratory system. I think all of these systems really require further studies to know whether or not they're going to become adopted by very many hospitals. Next slide. So in summary, there are an increasing number of newer surface disinfectants available for use in healthcare facilities. I think it's fair to say that no disinfectant is ideal for every situation and every pathogen, something that Bill Ratala pointed out. I think that greater attention should be devoted to making sure that disinfectants are used as recommended, to make sure that the product is going to be effective, and to avoid contamination, especially with clot disinfectants. I believe that wipes and cloth should be compatible with the disinfectant that's used, and there is now increasing evidence that no-touch room decontamination systems can be used in conjunction with manual disinfection processes to reduce the risk of healthcare-associated infections. Thank you for your attention. Now I'm going to turn it back to Paul. Paul?
Dr. Boyce, thank you very much. That was about as comprehensive as you can do, I think, in an hour. As you said, there's far more to say about this than really can be covered in just 60 minutes. But thank you very much for that. I wanted to ask, has there been noticed any tendency to cheat on cleaning, on the physical removal of organic debris when a facility is using an automated system?
You mean, do housekeepers maybe want to not do a very good job of manual cleaning before they use a no-touch system?
I guess that's what I'm asking. Yeah, is there a tendency to not be as careful with the cleaning, just the physical cleaning with a regular detergent or whatever they're using, if an automated system is being used?
I think that's a valid concern, Paul. It's interesting that when fogging systems were used back in the 1970s, that CDC found that housekeepers maybe didn't do such a good job of manual cleaning if they knew the room was going to be fogged afterwards.
Right.
And I wouldn't be surprised if some housekeepers today might kind of skimp over things somewhat if they know that one of the no-touch automated systems is going to be used for terminal disinfection. And so I think it's very important to remind housekeepers, first of all, of how important their job is and the important role that they play in reducing acquisition of pathogens, and that everybody that I know of who recommends or has tried using one of these automated systems still recommends that you clean the room first manually before you use the automated system.
I would, of course, tend to agree with that. And I wanted to ask your opinion. I saw at one of the conferences overseas, I saw a new disinfectant, liquid disinfectant that was being marketed using chlorhexidine gluconate as its active ingredient. I've only ever seen that once, and it was a few years ago. Perhaps it wasn't as successful as the manufacturers would have hoped, but do you have any comment on what is probably intended to be a skin antiseptic being used for that application?
Yeah, Paul, I'm not aware of that product, and I haven't seen any publications that have studied the efficacy of that. But as you pointed out, chlorhexidine is considered an antiseptic by most agencies and most healthcare people, rather than a surface disinfectant. And so clearly in the United States, at least based on current CDC guidelines, we wouldn't recommend using chlorhexidine as a surface disinfectant.
Well, thank you very much. I see our time has come, and in fact, a little bit past. So let me thank Sealed Air Diversity Care for their sponsorship of this teleclass today. It's been very valuable. Thank you. Thank you to all of you. On slide 59, you will see a list of teleclasses that are pending. I will leave those to you to read. We're getting close to the end of our 2016 schedule, and the 2017 schedule will be announced on December the 1st. It'll be posted online then. Thank you to all of you. Actually, we've been doing this for 15 years this year. This is our 15th anniversary, and thank you very much for your support all along, and to our patron sponsors as well, Sealed Air, Diversity Care, Virox, and the World Health Organization. Thank you to all of those. Dr. Boyce, to you, this has been, I think you packed in as much as you possibly could into that talk, and I know that it took you a lot of time to very carefully prepare the slides. I thank you for all of that effort and for doing what you've been doing for so many decades now. I have seen you speak, I think, at conferences on 3 different continents in the last decade and a half. And what you've done has been very, very valuable, and I think has changed the way we look at things. So thank you very much for your contribution. And
thank you, Paul, for all your efforts at producing these teleconferences over the year. I think they are well received and are quite valuable. And congratulations on 15 years of presenting.
Thank you very much. I will say thank you again to everyone else, and we will look forward to speaking to you again very soon. Goodbye.